don't stop. Don't stop. Don't stop. Don't stop. Don't stop.
Walls of pelvis. All the pelvic viscera, i.e. terminal parts of digestive and urinary system, and components of genital system are located in the pelvis. These organs are provided due protection and nutrition by the bones, muscles, fascia, blood vessels, lymphatics and nerves of the pelvis. The posterior superior iliac spine, seen as a dimple, mostly covered, lies opposite the middle of the sacroiliac joint. Contents: in this chapter the vessels, nerves, muscles, fascia, and joints of the pelvis will be considered. Remove the viscera from the pelvic wall and the pelvic cavity. Trace the internal iliac artery and its two divisions. Follow the branches of each of its divisions to the position of the viscera and the parieties. Remove the veins and venous plexuses as these obstruct the view of the arteries. Clean the hypogastric plexus. Internal iliac artery. The internal iliac artery is the smaller terminal branch of the common iliac artery. It is 3.75 centimeters long. It supplies 1 pelvic organs except those supplied by the superior rectal, ovarian, and median sacral arteries. 2 perineum. 3 greater part of the gluteal region. 4 iliac fossa. In the foetus, internal iliac artery is double the size of the external iliac artery because it transmits blood to the placenta through the umbilical artery. The umbilical artery with the internal iliac then forms the direct continuation of the common iliac artery. After birth the superior vesical artery, and the rest of it degenerates into a fibrous cord, the medial umbilical ligament. Course. The internal iliac artery begins in front of the sacroiliac joint, at the level of the intervertebral disc between the fifth lumbar vertebra and the sacrum. Here it lies medial to the psoas major muscle. The artery runs downwards and backwards, and ends near the upper margin of the greater sciatic notch, by dividing into anterior and posterior divisions or trunks. Relations: anterior, posterior, lateral, medial. Branches ureter. In female to the ovary and lateral end of the uterine tube, internal iliac vein, lumbosacral trunk, and the sacroiliac joint, external iliac vessels and obturator nerve. Peritoneum and to a few tributaries of the internal iliac vein. Branches of anterior division. In the male, it gives off 6 branches. 1 superior vesicle. 2 obturator. 3 middle rectal. 4 inferior vesicle. 5 inferior gluteal. 6 internal pudendal. The last 2 are the terminal branches. In the female, it gives off 7 branches. The inferior vesical artery is replaced by the vaginal artery. The uterine artery is the 7th branches. It gives off 1 iliolumbar, 2 lateral sacral, 3 superior gluteal arteries. Parietal branches of anterior division. 1 superior gluteal artery, it is the largest branch of the anterior division of the internal iliac artery. It is the mini artery of the lower limb. It supplies chiefly the buttock and the back of the thigh. In the pelvis, it runs downwards in front of the sacral plexus and piriformis. Next, it pierces the parietal pelvic fascia, passes below the first sacral nerve and then between the piriformis and the coccygus, and enters the gluteal region through the lower part of the greater sciatic foramen. In the pelvis, it supplies a muscular branches to nearby muscles, vesical branches to the base of the bladder, the seminal vesicles and the prostate. 2 obturator artery, it runs forwards and downwards on the obturator fascia below the obturator nerve and above the obturator vein, NAV. Medially, it is crossed by the ureter and the ductus deferens, and is covered with peritoneum. It passes through the obturator foramen to leave the pelvis and enter the thigh. In the pelvis it gives off a iliac branches to the iliac fossa, b a vesical branch to the urinary bladder, a pubic branch to the peritoneum on the back of the pubis, which anastomoses with the pubic branch of the inferior epigastric artery and with its fellow of the opposite side. Visceral branches of anterior division. Superior vesicle. The proximal 2.5 cm or so of the superior vesical artery represents the persistent part of the umbilical artery. It supplies many branches to the upper part of the urinary bladder. One of these branches gives off the artery to the ductus deferens. One middle rectal artery. It is characterized by three features. A. It is often absent, especially in female. A. Very little of its blood goes to the rectum, and that too goes only to its muscle coats. B. Most of its blood goes to the prostate and seminal vesicles. 2. Inferior vesical artery. It supplies the trigone of the bladder, the prostate, the seminal vesicles, and the lower part of the ureter. 3. Internal pudendal artery. It is the smaller terminal branch of the anterior division of the internal iliac artery. It supplies the perineum and external genitalia. Its branches are inferior rectal, perineal, artery to bulb, urethra, deep and dorsal arteries. 4. Vaginal artery. It corresponds to the inferior vesical artery of the male, and supplies the vagina, the bulb of the vestibule, the base of the urinary bladder, and the adjacent part of the rectum. 5. Uterine artery. It has a tortuous course. Crosses the ureter 2 cm lateral to cervix. Runs alongside of uterus. Supplies vagina, cervix, uterus, fallopian tube. Mnemonics to remember branches of internal iliac artery include: I love sex or pills. G. Posterior division. Suave you Mr. Pig, anterior division. I love going places in my very own underwear. Anterior and posterior divisions. Branches of posterior division. 1. Iliolumbar artery. It runs upwards in front of the sacroiliac joint and lumbosacral trunk, and behind the obturator nerve and external iliac vessels. Behind the psoas major, it divides into the lumbar and iliac branches. The lumbar branch represents the fifth lumbar artery, and supplies the psoas, the quadratus lumborum and the erector spinae. Its spinal branch supplies the cauda equina. The iliac branch supplies the iliac fossa and the iliacus. It participates in the anastomosis around the anterior superior iliac spine. 2. Lateral sacral arteries. These are usually 2 in number, upper and lower. They run downwards and medially over the sacral nerves. Their branches enter the 4 anterior sacral foramina to supply the contents of the sacral canal. Their terminations pass out through the posterior sacral foramina and supply the muscles and skin on the back of the sacrum. 3. Superior gluteal artery. It runs backwards, pierces the pelvic fascia, passes above the first sacral nerve, and leaves the pelvis through the greater sciatic foramen above the piriformis. It supplies gluteus maximus muscle. Also takes part in anastomosis around anterior superior iliac spine and in trochanteric anastomosis to supply nearby muscles and overlying skin. Internal iliac vein. It ascends posteromedial to the internal iliac artery, and joins the external iliac vein to form the common iliac vein at the pelvic brim, in front of the lower part of the sacroiliac joint. Its tributaries correspond with the branches of the artery, except for the iliolumbar vein which joins the common iliac vein. The tributaries are as follows. Veins arising in and outside the pelvic wall. 1. Superior gluteal is the largest tributary. 2. Inferior gluteal. 3. Internal pudendal. 4. Obturator. 5. Lateral sacral veins. Veins arising from plexuses of pelvic viscera. L. Rectal venous plexus is drained by the superior, middle, and inferior rectal veins. 2. Prostatic venous plexus is drained by the vesical and internal iliac veins. Vesical venous plexus is drained by the vesical veins. 3. Uterine venous plexus is drained by the uterine veins. 4. Vaginal venous plexus is drained by the vaginal veins. Lymph nodes of the pelvis. The pelvic lymphatics drain into the following lymph nodes, which lie along the vessels of the same name. 1. The common ilean nodes 4 to 6 receive lymphatics from the external and internal iliac nodes, and send their efferents to the lateral aortic nodes. 2. The external iliac nodes 8 to 10 receive lymphatics from the inguinal nodes, the deeper layers of the infra-umbilical part of the anterior abdominal wall, the membranous urethra, the prostate, the base of the urinary bladder, the uterine cervix, and part of the vagina. Their efferents pass to the common iliac nodes. The inferior epigastric and circumflex iliac nodes are outlying members of this group. 3. The internal iliac nodes receive lymphatics from all the pelvic viscera, the deeper parts of the perineum, and muscles of the buttocks and of the back of the thigh. Their efferents pass to the common iliac nodes. The sacral and obturator nodes are outlying members of this group. 4. Dissection. 5. Expose the lumbosacral trunk and ventral rami of sacral 1 to sacral 5 nerves. Lift the sacral plexus forwards and expose its terminal branches, the sciatic and pudendal nerves. 6. Find the nerves arising from the dorsal surface of plexus, e.g. superior gluteal, inferior gluteal, perforating cutaneous and perineal branch of 4th sacral nerve. Trace the 2 branches, e.g. nerve to quadratus femoris and nerve to obturator internus arising from the pelvic surface of the plexus. 7. Trace the sympathetic trunks in the pelvis till these terminate in the single ganglion impar on the coccyx. Trace the large gray rami communicans from the ganglia to the ventral rami of the sacral nerves. Find the inferior hypogastric plexus around the internal iliac vessels. In addition, trace the pelvic splanchnic nerves reaching the inferior hypogastric plexus from the ventral rami of 2nd, 3rd, and 4th sacral nerves. The nerves of pelvis include lumbosacral plexus. Pelvic splanchnic nerves. Lumbosacral plexus. Formation. The lumbosacral plexus is formed by the lumbosacral trunk and the ventral rami of the 1st to 3rd sacral nerves, and part of the 4th sacral nerve. The lumbosacral monk is formed by the descending branch of the ventral ramus of nerve L4 and the whole of ventral ramus L5. The trunk descends over the ala of the sacrum, crosses the pelvic brim in front of the sacroiliac joint, and joins nerve S1. Nerves S1 and S2 are large. The other sacral nerves become progressively smaller in size. Relations. L. The lumbosacral trunk and ramus S1 are separated from each other by the superior gluteal vessels. Both lie in front of the sacroiliac joint before passing onto the surface of the piriformis. Thus both may be involved in pathological conditions of the joint. 2. Ramus S1 is separated from ramus S2 by the inferior gluteal vessels. 3. Rami S2, S3, and a part of S4 lie between the anterior surface of the piriformis and the pelvic fascia. 4. The main plexus lies in front of the piriformis deep to the pelvic fascia, and behind the internal iliac vessels and the ureter. Layout of connections and branches. 1. Each ventral ramus receives a gray ramus comoidicaries from the sympathetic chain at the anterior sacral foramen. 2. Before uniting to form the plexus, the ventral rami give off A twigs to the piriformis, S1 S2. B twigs to the levator and the coccygus and the sphincter and externus, S4. C. Pelvic splenic nerves, S2 S3 S4. 3. The plexus gives rise to 2 main branches, namely, the sciatic and pudendal nerves, concerned respectively with locomotion and reproduction. 4. As in other plexuses, the rami tend to divide into ventral and dorsal divisions which supply the corresponding aspects of the lower limb and trunk. In general, the dorsal divisions supply the extensors and the abductors, and the ventral divisions supply the flexors and the adductors, of the limb. Bryan Ches. Branches derived from both dorsal and ventral divisions are as follows. 1. Sciatic nerve. The common peroneal nerve component arises from dorsal divisions of L4, L5, S1, S2. It supplies everters of foot and dorsiflexors of ankle joint. The tibial nerve component arises from ventral divisions of L4, L5, S1, S2, S3. It supplies the hamstring muscles, all muscles of calf and intrinsic muscles of the sole. This nerve is described in Chapter 7. 2. Posterior cutaneous nerve of thigh, dorsal divisions of S1, S2, and ventral divisions of S2, S3. Branches from dorsal ovisions. 1. Superior gluteal nerve, L4, L5, S1. 2. Inferior gluteal nerve, L5, S1, S2 nerve to piriformis SIS2 3P perforating cutaneous nerve S2 S3. Branches from ventral division. 1 nerve to quadratus infernus S1 S2.L5. 2 pudendal nerve, S2, S3, S4, supplies sphincter and externus and all muscles in urogenital triangles. 3 muscular branches to the levator ani, the coccygus and the sphincter ani externus, including perineal branch of nerve S4. 4 pelvic splanchnic nerve S2 S3 S4. Muscular branches. Nerves to the levator ani or iliacoccygeus part and the coccygus or ischiococcygeus arise from nerve S4 and enter their pelvic surfaces. The nerve to the middle part of the sphincter and externus is called the perineal branch of the 4th sacral nerve. It runs forwards on the coccygus and reaches the ischio-anal fossa by passing between the coccygus and the levator ani. In addition to the lower end of external sphincter, it supplies the skin between the anus and the coccyx. Coccygeal plexus. 1. It is formed by the ventral rami of spinal nerves S4, descending branch, S5 and the coccygeal nerve. 2. The 3 nerves join on the pelvic surface of the coccygus to form a small plexus known as the coccygeal plexus. 3. The plexus gives off the anacoccygeal nerves, which pierce the sacrotuberous ligament and supply the skin in the region of the coccyx. The lumbosacral trunk, L4, L5 and the ventral ramus of nerve S1 cross the pelvic surface of the joint and may be involved in disease of the joint, causing pain in the area or their distribution below the knee. L4 supplies medial aspect of 1 EG and sole. It supplies lateral aspect of sole refer. Pelvic autonomic nerves. Pelvic sympathetic system. The pelvic part of the sympathetic chain runs downwards and slightly medially over the body of sacrum, and then along the medial margins of the anterior sacral foramina. The 2 chains unite in front of the coccyx to form a small ganglion impar. The chain bears 4 sacral ganglia on each side and the single ganglion impar in the central part. The branches of the chain are, A. Gray rami commun icons to all sacral and coccygeal ventral rami. B. Branches to the inferior hypogastric plexus from the upper ganglia. C. Branches to the median sacral artery from the lower ganglia. D. Branches to the rectum from the lower ganglion. E. Branches to the glomus coccygeum from the ganglion impar. The inferior hypogastric plexus, 1 on each side of the rectum and other pelvic viscera, is formed by the corresponding hypogastric nerve from the superior hypogastric plexus, branches from the upper ganglia of the sacral sympathetic chain, and the pelvic splanchnic nerves. Branches of the plexus accompany the visceral branches of the internal iliac artery, and are named, A. Rectal plexus. 2. Vesical plexus. 3. Prostatic plexus. Utervaginal plexus. Pelvic splanchnic nerves. The nervi erigents. The nervi erigents represent the sacral outflow of the parasympathetic nervous system. The nerves arise as fine filaments from the ventral rami of S2, S3, and S4. They join the inferior hypogastric plexus and are distributed to the pelvic organs. Some parasympathetic fibers ascend with the hypogastric nerve to the superior hypogastric plexus and thence to the inferior mesenteric plexus. Others ascend independently and directly to the part of the colon derived from the hindgut. Pelvic fascia. The pelvic fascia is distributed in the extraperitoneal space of the pelvis. It covers the lateral pelvic wall and the pelvic floor called parietal pelvic fascia, and also surrounds the pelvic viscera called visceral pelvic fascia. Principles governing its distribution. 1. The fascia is dense and membranous over non-expansile structures, e.g. lateral pelvic wall, but is only loosely arranged over expansile structures, e.g. viscera, and over mobile structures, e.g. the pelvic floor. 2. As a rule the fascia does not extend over bare bones, at the margins of the muscles it fuses with the periosteum. In this respect, the fascia of Waldeyr is an exception, which extends from the sacrum to the ampulla of rectum. Parietal fascia of the lateral pelvic wall. 1. The fascia covering the muscles of the lateral pelvic wall is condensed to form thick and strong membranes. It is closely adherent to the walls of the pelvic cavity. It is attached along a line from iliopectineolin to the inferior border of pubic bone. 2. The fascia covering the obturator internus is called the obturator fascia. It shows a linear thickening or tendinous arch for the origin of the levator ani. Below this origin it is closely related to the lunate fascia and to the pudendal canal. 3. The fascia covering the piriformis is thin. The nerves over the piriformis, i.e. the sacral plexus, lie external to the pelvic fascia and, therefore, do not pierce the fascia while passing out of the pelvis. The gluteal vessels, on the other hand, lie internal to the pelvic fascia and, therefore, have to pierce the fascia while passing out of the pelvis. Parietal fascia of the pelvic floor. The pelvic fascia covers both the surfaces of the pelvic diaphragm, forming the superior and inferior layers. 2. In general, the fascia of the pelvic floor is loosely arranged between the peritoneum and the pelvic floor, forming a dead space for distension of the bladder, the rectum, the uterus, and the vagina. Because of the loose nature of the fascia, infections can spread rapidly within it. 3. However, the fascia is condensed at places to form fibromuscular ligaments which support the pelvic viscera. The various ligaments are dealt with individual viscera including the prostate, bladder, uterus, and the rectum. Visceral pelvic fascia. This fascia surrounds the extraperitoneal parts of the pelvic viscera. It is loose and cellular around DISceCTION organs like bladder, rectum, and vagina, but is dense around non-distensible organs, like the prostate. The visceral layer is attached along a line extending from the middle of back of pubis to the ischial spine. Dissection. Muscles of lesser pelvis, identify the origin of piriformis from the ventral surface of the sacrum. Trace it through the greater sciatic foramen to its insertion into the upper border of greater trochanter of femur. Feel the ischial spine and trace the fibresidential of coccygus and levator ani that arise from it. Trace the origin of levator ani from thickened fascia, i.e. tendinous arch over the middle of obturator internus muscle till the back of body of the pubis. Note that the right and left sheet-like levator ani muscles are united and the muscles are inserted into central perineal tendon or perineal body, anal canal, anacoccygeal ligament. Detach the origin of levator ani from obturator fascia. While removing obturator fascia, identify pudendal canal with its contents in the lower part of the fascia. Trace the tendon of obturator internus muscle. This tendon along with superior and inferior gemelli muscles leaves through the lesser sciatic foramen to be inserted into the medial surface of greater trochanter of femur. Features. The pelvic muscles include two groups. L. piriformis and obturator internus, which are short lateral rotators of the hip joint and are described with the muscles of the lower limb. 2. Levator ani and coccygus, which with the corresponding muscles of the opposite side, form the pelvic diaphragm. The diaphragm separates the pelvis from the perineum. The levator ani and coccygus may be regarded as one morphological entity, divisible from before backwards into the pubicoccygus, the iliacoccygus, and the ischiacoccygus or coccygus. They have a continuous linear origin from the pelvic surface of the body of the pubis, the obturator fascia or white line or tendinous arch, and the ischial spine. The muscle fibers slope downwards and backwards to the midline, making a gutter-shaped pelvic floor. These muscles are described below. The levator ani. The muscle is divisible into a pubicoccygus part, an iliacoccygus part, and a ischiacoccygus part. Pubicoccygus part. The anterior fibers of this part arise from the medial part of the pelvic surface of the body of the pubis. In the male, these fibers closely surround the prostate and constitute the levator prostatae. In the female, these fibers surround the vagina and form the sphincter vaginae. In both cases, the anterior fibers are inserted into the perineal body. 2. The middle fibers constitute the puborectalis. These arise from the lateral part of the pelvic surface of the body of the pubis. They partly form a loop or sling around the anorectal junction, and are partly continuous with the longitudinal muscle coat of the rectum. In female, the anterior portion of puborectalis is thinner and shorter. 5. The posterior fibers of the pubicoccygus arise from the anterior half of the white line on the obturator fascia. These get attached to anacoccygeal ligament and tip of coccyx. Iliacoccygeus part. The fibers of this part arise from 1. The posterior half of the white line on the obturator fascia. 2. The pelvic surface of the ischial spine. They are inserted into the anacoccygeal ligament and into the side of the last two pieces of coccyx. Coccygeus. This muscle represents the posterior or ischiococcygous part of the pelvic diaphragm. It is triangular in shape. It is partly muscular and partly tendinous. Its fibers arise from the pelvic surface of ischial spine. A. The sacrospinous ligament. It is inserted into the side of the coccyx, and into the fifth sacral vertebra. Nerve supply. The levator ani is supplied by 1. A branch from the fourth sacral nerve. 2. A branch from the inferior rectal nerve. The coccygeus is supplied by a branch derived from the fourth and fifth sacral nerves. Actions of levators ani and coccygeus. 1. The levators ani and coccygeus close the posterior part of the pelvic outlet. 2. The levators act fix the perineal body and support the pelvic viscera. 3. During coughing, sneezing, lifting, and other muscular efforts, the levators ani and coccygii counteract or resist increased intra-abdominal pressure and help to maintain continence of the bladder and the rectum. In micturition, defecation, and parturition, a particular pelvic outlet is open, but contraction of fibers around other openings resists increased intra-abdominal pressure and prevents any prolapse through the pelvic floor. The increase in the intra-abdominal pressure is momentary in coughing and sneezing and is more prolonged in yawning, micturition, defecation and lifting heavy weights. It is most prolonged and intense in second stage of labor. 4. The coccygeus pulls forwards and support the coccyx, after it has been pressed backwards during defecation, parturition, or childbirth. Relations of the levator ani. 1. The superior or pelvic surface is covered with pelvic fascia which separates it from the bladder, prostate, rectum, and the peritoneum. 2. The inferior or perineal surface is covered with anal fascia and forms the medial boundary of the ischio-anal fossa. 3. The anterior borders of the two muscles are separated by a triangular space for the passage of the urethra and the vagina. 4. The posterior border is free and lies against the anterior margin of coccygeus. Morphology of pelvic diaphragm. In lower mammals, both the pubicoccygeus and the iliacoccygeus are inserted only into the coccygeal vertebrae and are responsible for movements of the tail. With the disappearance of the tail during evolution, the muscles have been modified to form the pelvic diaphragm which supports the viscera. Such support became necessary with the adoption of the erect posture by man. 2. In lower mammals, the levator ani arises from the pelvic brim. In man, the origin has shifted down to the side wall or the pelvis. 2. The coccygeus muscle corresponds exactly with the sacrospinous ligament, which is a degenerated part of the aponeurosis of this muscle. The two are inversely proportional in their development. The muscles of the pelvic floor may be injured during parturition. When the perineal body is torn, and has not been repaired satisfactorily, the contraction or anterior fibers of the levator ant increases the normal gap in the pelvic floor, instead of decreasing it. This results in prolapse of the uterus. Dissection. Joints. Remove the remains of any muscle of the back or thoracolumbar fascia. Identify the iliolumbar and dorsal sacroiliac ligaments. Remove the dorsal sacroiliac ligament to identify the deeply placed interosseous sacroiliac ligament. Divide this interosseous ligament and open the joint from the posterior aspect. Define the attachments of ventral sacroiliac ligament. Cut through this thin ligament to open the sacroiliac joint. The following parts are considered. 1. Lumbosacral joint. 2. Sacrococcygeal joints. 3. Sacroiliac joint and vertebral ligaments. 4. Pubic symphysis followed by the mechanism of pelvis. Lumbosacral joints. 1. The joints and ligaments between the fifth lumbar vertebra and the base of the sacrum are similar to those between any two typical vertebrae. The lumbosacral disc is very thick, and is thickest anteriorly. 2. The stability of the fifth lumbar vertebra on the sacrum is further increased by, a. the widely spaced articular processes. B. Strong iliolumbar ligaments which extends from the stout transverse process of the fifth lumbar vertebra to the iliac crest. The ligament fans out inferiorly to be attached to the lateral part of the ala of the sacrum as the lumbosacral ligament. 3. The body of the fifth lumbar vertebra makes an angle of about 120 degrees, opens backwards with the sacrum. This is the lumbosacral or sacrovertebral angle, and opens backwards. 4. This region is subject to a number of variations which give rise to symptoms of backache. These are, A. Sacralization of the fifth lumbar vertebra. B. Lumbralization of the first sacral vertebra. C. Spina bifida. D. Spondylolisthesis, etc. Sacrococcygeal and intercoccygeal joints. The sacrococcygeal joint is a secondary cartilaginous joint between the apex of the sacrum and the base of the coccyx. The bones are united by, 1. A thin intervertebral disc. 2. Ventral sacrococcygeal ligament corresponding to the anterior longitudinal ligament. 3. Deep dorsal sacrococcygeal ligament corresponding to the posterior longitudinal ligament. 4. Superficial dorsal sacrococcygeal ligament, completing the lower part of the sacral canal. 5. Lateral sacrococcygeal ligament corresponding to the intertransverse ligament and completing the foramen for the fifth sacral nerve. 6. Intercornual ligament, connecting the cornua of the sacrum and the coccyx. In old age the joint is obliterated and the ligaments are ossified. Sometimes the joint is synovial, and the coccyx is freely mobile. The intercoccygeal joints are present only in young subjects. Fusion of the segments begins at the age of 20 years and is complete by about 30 years. Sacroiliac joint, type, this is a synovial joint of the plane variety. The articular surfaces are flat in infants, but in adults show interlocking irregularities which discourage movements at this joint. Articular surface. The joint is formed between, 1. Auricular surface of the sacrum, which is covered with fibrocartilage. 2. Auricular surface of the ilium, which is covered with hyaline cartilage. Ligaments. 1. The fibrous capsule is attached close to the margins of the articular surfaces. It is lined by synovial membrane. 2. The ventral sacroiliac ligament is a thickening of the anterior and inferior parts of the fibrous capsule. Its lower part is attached to the preauricular sulcus. 3. The interosseous sacroiliac ligament is massive and very strong, forming the chief bond of union between the sacrum and the ilium. It connects the wide, rough areas adjoining the concave margins of the auricular surfaces, and is covered by the dorsal sacroiliac ligament. 4. The dorsal sacroiliac ligament covers the interosseous sacroiliac ligament, from which it is separated by the dorsal rami of the sacral spinal nerves and vessels. 5. Dorsal sacroiliac consist of, A. Short transverse fibers or short posterior sacroiliac ligament passing from the ilium to the transverse tubercles of the first two sacral pieces. B. A long, more vertical, band or long posterior sacroiliac ligament passing from the posterior superior iliac spine to the transverse tubercles of the third and fourth sacral pieces. It is continuous laterally with medial edge of the sacrotuberous ligament. 6. The vertebropelvic ligaments include the iliolumbar, sacrotuberous and sacrospinous ligaments. These are accessory ligaments to the sacroiliac joint and are important in maintaining its stability. A. The iliofemoral ligament is a strong, triangular ligament, extending from the thick transverse process of the fifth lumbar vertebra to the posterior part of the inner lip of the iliac crest. It is continuous with the middle and anterior layers of the thoracolumbar fascia and gives partial origin to the quadratus lumborum. It is covered anteriorly by the psoas, and posteriorly by the erector spinae. It prevents antero-inferior slipping of the fifth lumbar vertebra under the influence of body weight, and also prevents forward movement at the sacroiliac joint. B. The sacrotuberous ligament is a long and strong band which forms parts of the boundaries of the pelvic outlet and of the sciatic foramina. Its superomedial end or base is wide. It is attached to the posterior superior and posterior inferior iliac spines, the lower transverse tubercles of the sacrum, the lateral margin of the lower part of the sacrum and the upper part of the coccyx. The inferolateral end is narrow. It is attached to the medial margin of the ischial tuberosity. A part of it that extends along the ramus of the ischium is called the falciform process. The ligament is covered by and also gives partial origin to gluteus maximus, and is pierced by the perforating cutaneous nerve, the fifth sacral and first coccygeal nerves, and branches of the coccygeal plexus. See, the sacrospinous ligament is a thin, triangular ligament, which lies deep to sacrotuberous ligament, and separates the greater and lesser sciatic foramina. Its base is attached to the lateral margins of the last piece of the sacrum and to the coccyx, and its apex to the ischial spine. Its pelvic surface is covered by and also gives origin to the coccygus. Morphologically, the ligament is a degenerated part of the coccygus. The sacrotuberous and sacrospinous ligaments bind the sacrum to the ischium. They oppose upward tilting of the lower end of the sacrum and therefore, downward tilting of its upper end under body weight. Relations. Posteriorly, zero joint is covered by the erector spinae, the gluteus maximus and the sacrotuberous ligament. One dimple overlying the posterior superior iliac spine lies opposite the middle of joint. Abdominal surface. 1. It is covered by the psoas and iliacus. 2. Deep to the psoas, the joint is crossed by the iliolumbar vessels and the obturator nerve. 3. Femoral nerve is separated from the joint by the iliacus muscle. The pelvic surface is related to 1. Lumbosacral trunk and the posterior division of the internal iliac artery. 2. Internal iliac vein and the anterior division of the internal iliac artery. 3. Superior gluteal vessels and the first sacral nerve, S1. 5. Upper part of the piriformis. Factors providing stability. Stability is the primary requirement of the joint as it transmits body weight from the vertebral column to the lower limbs. Stability is maintained by a number of factors which are as follows. 1. Interlocking of the articular surfaces. 1. Thick and strong interosseous and dorsal sacroiliac ligaments play a very important role in maintaining stability. 2. Vertebropelvic ligaments, i.e. iliolumbar, sacrotuberous and sacrospinous, are equally important in this respect. 3. With advancing age, partial synostosis of the joint takes place which further reduces movements. Blood supply. Sacroiliac joint is supplied by twigs from all the three branches of posterior division of internal iliac artery, i.e. iliolumbar, lateral sacral and superior gluteal arteries. Nerve supply. The joint is supplied by the following nerves: superior gluteal, 1. Ventral rami and the lateral branches of dorsal rami of the first and second sacral nerves. Movements. During flexion and extension of the trunk, stooping and straightening, i.e. the sacroiliac joint permits a small amount of antero-posterior rotatory movement around a transverse axis passing 5 to 10 cm vertically below the sacral promontory. This little movement serves the important function of absorbing the shocks of jumping and bearing of loads. The range of movement is increased temporarily in pregnancy, in which all the ligaments of the pelvis become loose, under the influence of hormones, to facilitate delivery of the foetus. Pubic symphysis. This is a secondary cartilaginous joint between the bodies of the right and left pubic bones. Each articular surface is covered with a thin layer of hyaline cartilage. The fibrocartilaginous disc is reinforced by surrounding ligamentous fibers. The fibers are thickest inferiorly where they form the arcuate cubic ligament. Anteriorly, the fibers form the anterior cubic ligament. The pubic symphysis permits slight movement between the hip bones, which helps in absorbing shocks. The range of movement is increased during pregnancy. The mechanism of pelvis. The most important mechanical function of the pelvis is to transmit the weight of trunk to the lower limb. The weight passes mainly through the ale of sacrum and through the thick part of hip bone lying between sacroiliac joint and acetabulum. Theoretically, the weight falling on the lumbosacral joint is divided into two components. One component of the force is expanded in trying to drive the sacrum downwards and backwards between the iliac bones. This is resisted by the ligaments of pubic symphysis. Second component of the force tries to push the upper end of sacrum downwards and forwards towards the pelvic cavity. This is resisted by the middle segment of the sacroiliac joint, where the auricular surface of the sacrum is wider posteriorly, i.e. wedge-shaped, and is concave for interlocking with the reciprocal surface of the ilium. Because of the poor wedging and poor locking of the articular surfaces in the anterior and posterior segments of the sacroiliac joint, the sacrum is forced to rotate under the influence of body weight. In this rotation, the anterior segment is tilted downwards and the posterior segment upwards. The downward tilt of the anterior segment is prevented chiefly by the dorsal and interosseous sacroiliac ligaments, and the upward tilt of the posterior segment is prevented chiefly by the sacrotuberous and sacrospinous ligaments. During all these movements, the separation of iliac bones is resisted by sacroiliac and iliolumbar ligaments, and the ligaments of pubic symphysis. During pregnancy, the pelvic joints and ligaments are relaxed, so that the range of movement is increased and locking mechanism becomes less efficient. This naturally puts greater strain on the ligaments. The sacroiliac strain thus produced may persist even after pregnancy. After childbirth, the ligament are tightened up again, so that the locking mechanism returns to its original efficiency. Sometimes locking occurs in the rotated position of the hip bones adopted during pregnancy. This results in sbhlbcaphion of the joint, causing low backache due to strain on ligaments. The diseases of lumbosacral and sacroiliac joints can be differentiated by the following tests. A. In lumbosacral lesions, the tenderness is present over the spines and above the dimple of posterior superior iliac spine, over the iliolumbar ligament. In sacroiliac lesions, the tenderness is located inferomedial to the dimple, over the posterior sacroiliac ligament. B. In lumbosacral disease, the movements of vertebral column are restricted in all directions. In sacroiliac disease, the movements are free, except for extreme forward bending, when the tension on hamstrings causes backward rotation of the hip bones, opposite to that of sacrum, producing pain in a diseased joint. C. Inferior gluteal artery is the largest branch of anterior division of internal iliac artery. It is also part of the axial artery of lower limb. D. Pelvic viscera are supported by pelvic diaphragm formed by levator ani and coccygeus muscles in the large posterior part of pelvic outlet. In its small anterior part, the muscles of urogenital region support the viscera. C. Inferior vesicle is replaced by vaginal artery in female. D. Uterine artery is the additional artery exclusively in the female. E. Ventral ramus of L4 nerve takes part both in formation of lumbar plexus as well as sacral plexus and is called nervi furcalis. F. Nerves forming sacral plexus lie outside the parietal layer of pelvic fascia. Blood vessels of the pelvis lie inside the parietal layer. G. Interosseous sacroiliac ligament is the strongest ligament of the body. H. The free anastomosis between superior rectal vein of portal and the middle and inferior rectal veins of the caval system explain the metastases in the liver from cancers of the genital organs. I. The sensory nerve supply of the ovary and fallopian tube is from T10-T12 nerves.